Again, good evening, everyone. We're having today's Tuesday, January the 5th, and we're having our stated meeting for Burlingame Lodge number 400. But before that, we have a special presentation tonight. I see we have guests from the lodges, family members. So welcome all. Without further ado, I will let our senior warden, Brother Dennis Silva, make the proper introductions. Brother Dennis, please.
Thank you, Worshipful Master. Brethren, family, and friends, our guest speaker for tonight is an infectious disease physician. She is the controller and health officer of the TB department in San Mateo County Public Health. She's here to discuss the details of COVID-19 vaccine. It is my honor to introduce to you my co-worker, Dr. Lisa Gooze.
Thank you very much. I want to thank Mr. Dennis Silva for inviting me this evening. What I plan to do is give a very general overview, first of vaccines in general, and then specifically about the two COVID-19 vaccines that are available in the United States. I don't know who's in the audience, but my plan is to keep this pretty simple. So if there are medical people on the call, forgive me if this is too basic for you. Okay, so I'm just going to start. I wanted to start with just what are vaccines, how do they work in general? And as a background, there are germs everywhere in our environment and even living on us and in us on our skin, and that we're susceptible to that can cause infection. And these pathogens, so pathogen is just a word that can mean viruses, bacteria, fungi, but in this case, the pathogen we're talking about is a COVID virus. So, and I'm also going to use my notes, I apologize. So when the pathogen infects us and enters our body, the body's normal immune system will attack the pathogen and destroy it if you're healthy. Now, pathogens, and in this case, the coronavirus, is made up of many parts. And some parts of these viruses are called antigens. So they're just proteins of the virus. And the antibodies are formed against specific parts of the virus. So you can have more than one antibody against the same virus. They're directed at different parts. So with the coronavirus, one of the antigens that everybody talks about is called the spike protein. And the spike protein is what is involved in entering our cells and causing the infection. So the spike protein is what these vaccines are targeting. So if you're naturally infected with coronavirus, your body will make antibodies to the spike protein and hopefully help to block infection if you were to get infected again or exposed again. It takes a while to make the antibodies. So the antibody production the first time around, you know, in some people it can help, and some people it doesn't happen fast enough to help. So again, usually antibodies are produced naturally when we're infected to things, whether it's the flu virus, chicken pox, you know, we form antibodies to all these organisms. So some vaccines are all different. In the past, most vaccines are made from a piece of the virus or a piece of the bacteria, not necessarily the whole live pathogen. Most viruses, again, are what we call inactivated. So they're not live. And so when you get the flu shot, even though some people think the flu shot's giving them the flu, it can't give you the flu because it's not a live virus. So the flu virus contains part of the killed flu virus. The pneumonia vaccine, some of you may have heard of pneumonia vaccines, they actually contain the sugars that are on the bacteria that causes pneumonia. The two COVID vaccines use a different mechanism. They're called RNA viruses. So, and it's messenger RNA or mRNA you might see in the news. So the RNA viruses, the RNA serves as a blueprint to make the proteins for the virus. So this isn't really a new technology. It's a new technology for vaccinations, but RNA therapies have been used for cancer therapeutics for a while now. So the idea is that these two vaccines in the United States are made up of messenger RNA. So it's not a live virus in the vaccine. It's again, what's called RNA. So it's a piece of the virus that codes for the spike protein. So what happens is when the vaccine is injected, your body's cells, the messenger RNA will direct your body's cells to make a piece of the spike protein. Once it makes a piece of the spike protein, then the body naturally says, well, this isn't normal. This is like a foreign invader. So the body's natural response is to make antibodies to this spike protein. And so the hope is that then you get the vaccine, you make antibodies to the spike protein so that then if you're exposed down the road, your body will respond with these spike protein antibodies and prevent infection because it blocks entry of the virus into your cells. Okay, let's see. So again, I think a couple things are important. The RNA viruses do not use the live virus that causes COVID. So a lot of people are worried about the vaccine because they think it's a live virus, and it's not. The piece of the protein that the body produces, so again, the RNA that goes into your body directs the production of a piece of the spike protein, but it's just a piece of the whole virus. So that cannot cause an infection itself. So giving you the vaccine cannot give you the infection. The other thing is that the RNA never enters what we call the nucleus of the cell. So it never gets into your genetic material. It never gets into your genes. So some people are concerned about that by getting this vaccine, it's going to alter your genes. And that isn't scientifically possible. And the other thing is the reason RNA, it's actually talking to people who are basic scientists in the lab, RNA is very difficult to work with because it is so fragile. So it's destroyed right away. And actually that's part of the technology of the vaccines. It has to be in a fatty layer to keep it stable when it's injected to get into your body. So it's not destroyed right away. Okay. And once the RNA in the body directs the production of the protein, then the RNA is destroyed in your body and it's gone. So what are the vaccines that we have right now in the United States? There's two of them. One is the Pfizer vaccine that was approved on December 11th for what's called emergency use authorization. And then a week later, the Moderna vaccine was approved. Again, emergency use authorization. Again, they're both RNA vaccines. They work the same way. But there's a couple important differences about these two vaccines. One is that with the Pfizer, it has to be kept at least minus 70 degrees. So that poses some problems in terms of delivering this vaccine, of where it can be delivered to. If you think about clinics, they don't have, minus 70 freezers available. If you think about rural areas, it poses a lot of technical problems, whereas the Moderna vaccine basically is the same, needs to be kept at the temperature as a normal freezer that you might, that you'd have in your kitchen. So it's easier in that sense. The other main difference is, well, they're both 2 doses. But the difference is the Pfizer vaccine, you have to give 21 days apart, and the Moderna vaccine is 28 days apart. So Pfizer's 3 weeks, Moderna's 4 weeks apart, but they're both 2 doses. You're not supposed to mix vaccines. So you're not supposed to get the first dose of one vaccine and then the second dose of another vaccine. I just read today, and I don't know the details, honestly, but apparently there were some articles published proposing that people do mix the vaccines, or that people only give one dose in an attempt to vaccinate more people around the world. But right now, people are saying there's no data on this. There's no data what happens if you give, dose number 1 is Moderna, dose number 2 is Pfizer. I mean, you'd think it would work, but we just don't know. So at least in the United States, people are saying, stick to the guidelines. Let's see what else. Oh, the other thing, just it's more of a technical thing, is the vaccines come in vials, and once the vial is thawed, you can't put it back in the freezer. And the reason this is important is because you don't want to waste any. So it is a challenge for clinics, for hospitals to administer the vaccine, because they have to know exactly how many people they can vaccinate at a time. Because if they don't have enough people, if say the vial is 10 vaccines, well, you want to get 10 people because you don't want to have to waste it, because you can't refreeze it. So there's some stories, and it's causing some problems you may end up reading about on the news. So what's with the vaccines, and do they work? So both of them basically are considered to be 94 to 95% effective in preventing infection. And for the Pfizer vaccine, they each had about 30 to 40,000 people in their clinical trials. And the numbers are constantly changing because these same people in the trials are still being followed. So data that could have been published a few weeks ago would be changed now, but it's not necessarily available, data that's going on in these studies. But for the Pfizer vaccine, what they did was half the people got the vaccine, half the people got a fake vaccine, a placebo vaccine, and then they followed who got infected and who did not. And they found that this data is a little bit old, but for Pfizer, they basically had 170 cases of COVID infection at the time that everything was submitted to the FDA, and 162 of these infections occurred in the placebo group, but only 8 infections occurred in the vaccine group. And that's how they came out with 95% efficacy. With a Moderna vaccine, there was about 196 patients that got infected. 185 were in the placebo group, and 11 were in the vaccine group. And this is how they came up with the 94.5% efficacy. And importantly, in the Moderna trial, there were 30 cases of severe COVID, which is people requiring hospitalization or people requiring ICU stays, but all the severe cases occurred in the placebo group. There were no severe cases in the people that received the vaccine. So a couple questions come up about these vaccines. One is, do I have to get the second shot? Can I just get one? Now, there are some data that say with one vaccine, you might get about 50% protection. Other data say you could get up to 80 or 90% protection. But again, nobody really knows. You'd have to do that study where you just give people one dose and then follow them over time to see how effective it is. So right now, people are really recommending that you get both doses to achieve this 95% effectiveness. And protection usually occurs about 7 to 14 days after your second dose, and then you're considered protected. So again, I said before, you shouldn't mix the 2 vaccines. You shouldn't get one type for dose number 1 and a different for dose number 2. The other thing is that may come up that people may or may not think about is you are not supposed to get another vaccine within 2 weeks of the COVID vaccine. So whether that's the flu shot, or I was talking to someone who was due for her second shingles vaccine, you have to time it because you don't want, again, you just need to separate them by 2 weeks because if the body's, body's immune response is working against one vaccine and then you give another vaccine 2 days later, you don't know how effective that second vaccine will work. So you want to separate them out in time. What else? Some people are worried that this happens so fast. Wow, this has been barely a year. Are these vaccines, okay, because this happened so fast? But part of it is that China shared the genetic code immediately. I think it was last January. And scientists all over the world just started working on making a vaccine right away. And the FDA sped up the process, but kept all the safety processes in check. So it still had its normal phase 1, phase 2, and then the phase 3, which was the big trial. But the red tape and the bureaucracy was reduced in the process. So that was one of the big reasons why this happened so fast. And also apparently it's easier to make RNA vaccines technically than the other type of vaccines. So that's another reason why it could happen so fast. So what about safety of the vaccine? Sorry. Well, in terms of side effects, and again, this is data all from the clinical trials, the phase 3 clinical trials. So both vaccines have mild side effects that include tenderness or pain at the site of where the shot goes in. You might get some redness there. You might feel a little headachy, mild fever, chills. Most of those things, though, are more common after the second dose. So after the first dose, you might get some pain, some redness, maybe some mild symptoms. But per experience in the literature, it's much more common to get these other side effects after the second dose. So I know a lot of people talk about in the healthcare situation, you want to stagger when people get their vaccines, because if you give everyone the second dose on a Monday, then you might have a lot of people calling in sick over the next couple days. So like I know our director in the clinic I'm working in, she wants everyone to get the second dose on a Friday. So if we don't feel well, it's over the weekend and we're all back to work on Monday. So it's just, it's probably maybe not pleasant to feel achy or feverish or have a headache, but it's really, for me, that's better. I rather do that than have COVID. Usually these side effects only last a day or two. Now, interestingly, symptoms are more common in younger recipients, and they define younger as age 18 to 55. And they do say, guidelines say that you can give Tylenol if you develop any side effects, but it is not recommended to pre-medicate with Tylenol in anticipation of any side effects. And that's because it's really not known if Tylenol will affect the body's immune response to the vaccine. So it's better to just use Tylenol if you get side effects. Now, the other big thing I'm sure you've all heard about is the anaphylactic reactions. And so the first we heard, so there was no episodes of anaphylaxis in either trial. The first thing we heard about was in the United Kingdom. There were 2 episodes of anaphylaxis with the Pfizer vaccine because they started before the United States. Now in the United States, I can't tell you how many episodes there are because they're probably being reported a lot and that number isn't available. I mean, at first it was in the news, there were 6, there were 8, there were 10. But I know there's been at least one case in our hospital with someone getting vaccinated. So I'm sure it's happening. I don't have a total number in the United States. It has also happened with the Moderna vaccine. So it's not felt to be more related to one vaccine versus the other. It is not clear exactly what is causing the anaphylactic reaction. The vaccine, besides the mRNA, it has these fat molecules in it. It has preservatives in it. It has all types of things in it. There's a full list on the CDC website. You can look up all the ingredients in the vaccine. So it's not clear yet exactly what's responsible. So the vaccine is not recommended for people that have had a history of anaphylaxis to another vaccine. If you have an allergy to food, an allergy to animals, an allergy to oral medication, you can still get the vaccine. The only contraindication, the only reason you shouldn't get the vaccine if you want it, is if you've had this serious anaphylactic reaction to another vaccine. Having said that, there are people, you can look up the vaccine you had in the past, if you had a reaction, and the COVID vaccines, and see if any of the ingredients are the same. It's felt that if the ingredients are completely different, it's possible you can get the vaccine, and it's recommended that you speak to an allergist about this. So again, I think we'll find out more about these reactions as time goes on. Let's see. So just some other things in the studies, they did look at all ages. I shouldn't say that. They look in the Pfizer vaccine is recommended for people 16 years old and up. The Moderna vaccine is recommended for people 18 years old and up. However, they did look at all ages above those. So it wasn't like this was all in 30-year-olds. They had, people in their 60s, 70s, 80s, et cetera, receive this vaccine. They had people with all kinds of medical problems receive this vaccine, people with diabetes, heart problems, immunocompromised conditions, cancer. So they weren't excluded from the phase 3, the last big trial. So none of those are considered a contraindication or a reason to not get the vaccine. Asthma isn't a reason to not get the vaccine. The other thing may come up about pregnant women. Can they get the vaccine? So it's not really known. And most people, the safety isn't known yet, but most people feel that if you're in a group where the vaccine would be indicated, like if you're a nurse in the hospital seeing COVID patients, you would be in a group that's recommended to get the vaccine. And if you're pregnant, it is recommended that you get the vaccine. So it's, again, being pregnant or breastfeeding is not a contraindication. Again, this vaccine is not a live virus and it's destroyed really fast in your body. But it's something you should talk to your doctor about, certainly. How long will immunity last? Nobody knows. So it's felt with the natural infection, you're immune for about 90 days or 3 months. Nobody, we will find out with time. These people in the trial, they'll be followed over months. And so we'll have data eventually on how long people are immune from the vaccine, but right now we just don't know. Just a word about the rollout of the vaccine. So the first group is healthcare personnel and long-term care facility residents and staff. And that's that's happening right now. The next group is going to be the essential frontline workers and people that are 75 years old or over that. California is actually going to formulate guidance, and they're going to come out with this guidance to break up this group because, who's essential frontline workers? That encompasses a lot of people. Those could be people working in markets, firefighters, teachers. So the state is going to come up with more detailed guidance. The group after that is going to be people ages 65 to 74, or people 16 to 64 with high-risk medical conditions. And then the last group is basically everybody else. So the last thing I'm just going to mention that people want to know is, if I have the vaccine now, can I stop wearing a mask and get together with everybody like before? And the answer, unfortunately, is no, not yet. It's recommended that everyone continue what is recommended now, which is wearing a mask, washing your hands, social distancing. And the reason is because the vaccine isn't 100%. So you could still get COVID infection. You could have it after vaccination and not know it, and you could pass it to someone else. So for now, it's still recommended to continue all the safety measures that we're using now. So that hopefully was a quick run through of some basics on the vaccine. If anyone has any questions, I can try to answer them.
I have a question, Western Master, if I may.
Please.
Thank you for that talk. I know that when we receive flu vaccines, we're sometimes offered a vaccine that doesn't have a latex allergy reaction. Do you know if this is going to be a problem?
Interestingly, I just read about that today, and there's no latex at all in this vaccine or in the production of vaccine. So it's something I read specifically said if you have a latex allergy, it is okay to get the vaccine.
Thank you.
Worshipful Master, I have a question.
Please.
If I get tested for antibodies and I'm positive for antibodies, is there still benefit to take the vaccine as well?
So the answer is yes. So people that have COVID, it's actually recommended not while they're actively ill or within their isolation period, but it is recommended to have the vaccine after you have COVID infection. So if you have antibodies, then that means you had it at some point in time. So it is still recommended to get the vaccine. Now, if you knew when you had it, again, it's felt that you're immune for at least 3 months from natural infection. So it's again, because it's a scarce commodity right now, it's recommended to you that you can wait the 3 months if you knew when you had the infection. But I would say yes, even if you have the antibodies right now, you know, there may not be a huge rush, but eventually it is recommended to get the vaccine. They're recommending, like, people that have vaccine number 1 and then get infected, that those people also get vaccine number 2. Maybe not at the 3 or 4 week point, but to eventually receive the second vaccine.
Great, thank you.
Sure.
There's another question, let's see, from one of the brothers here, John Shield. Has Pfizer, Moderna started any additional trials regarding single dosing or different time frame between doses? Have they tried checking for that at this point, or?
Right. That's a good question. And honestly, I don't know the answer. I know both are looking at the use in pediatrics and younger children, but I don't know if they're looking at one dose or the different intervals between the 2 doses. I don't know. They might be.
One other thing, regarding the new mutations that we're hearing, how does that work with the vaccine? Does it alter the efficacy of it, or are we still?
So everything I've heard says that people or the experts feel that the vaccine should still work, so that it shouldn't change anything right now. Apparently this variant is felt to be more easily transmitted, but that it doesn't necessarily cause more severe disease. And again, what I've read is that there isn't a reason right now to think that the vaccine won't work.
Okay. Regarding herd immunity, we keep hearing about it. What % of the population needs to be vaccinated to achieve that? Or what is the thought?
You know, I know Dr. Fauci has, talks about that in the news, and I think keeps increasing the number. Like maybe way back it was 60%, and then he said it should be closer to 80, 90%. So I unfortunately, I can't really add to that. I don't know exactly.
And I have one more, at least for myself. What's the % now of major side effects? Since I know there is always a concern of side effects receiving the vaccine, what % of the population receiving the vaccine is actually experiencing those major side effects, like the anaphylactic reaction? I know it's not clear yet, but.
Yeah, so I don't think we have a number, because my guess is that, you can like Google it and you'll read, you know, this person in this city at this hospital had an anaphylactic reaction. But for example, you know, I know someone in our hospital did have an anaphylactic reaction, but that's not out in the news. So the Moderna and Pfizer everything has to be reported. So all the anaphylactic reactions are being tracked. But as of today, I don't know what the number, you know, you'd have to know, right, the number of everyone vaccinated and the number of people who've had anaphylactic reactions. And I'm not sure that's available yet.
Okay.
And it's probably changing, right, daily, unfortunately.
Any other questions in the crowd? No.
Worshipful Master, I have one more. It's a comment and also a question, and that's I've heard a few medical professionals talking about vitamin D levels and the correlation between symptoms and vitamin D levels and those who have severe cases and their vitamin D levels. Do you have any commentary on that, or am I way off in left field?
No, I don't think you're in left field. There has been some reports that people with lower vitamin D levels have had more severe courses of COVID infection and have had more severe complications. I don't, you know, there's not tons of information published on this. So I think it goes back to personal style. You know, some people believe in vitamin D in general, not having anything to do with COVID. You know, other people don't necessarily believe in vitamin D or vitamins. So, I mean, I have my own opinion, but, you know, I think there has been data that shows that just what you said, that lower vitamin D levels have been associated with more severe outcomes, but there hasn't been a lot of studies. So there could be other studies that maybe would say it doesn't make a difference.
Okay, thank you.
Sure.
Any other questions? You probably have time for one or two more.
I've got one more then, if no one else is going to say anything.
Please.
So if the antibodies we develop only persist, say, for 3 months, and we're sheltering in place, how is it? I'm speculating that then we could continue to get the virus over and over and over. If am I making sense here? Like, if you only have the antibodies for 3 months, then let's say then you crawl out of your cave after 4 months and then you get it again. You don't feel good. You go hunker down. You develop antibodies, but you're still sheltering in place, you know, ad nauseum.
Yeah, so how's this going to ever end? So I think there's a few things. One, we're hoping that it's longer than 3 months. Again, as time passes, we'll know. That's one point. The other point that may or may not pertain to your question is it's felt that if you do get infected with COVID after vaccination, that it's a milder case. That's not necessarily relating to your question. Now, there are some things like hepatitis B, as in boy, that people are vaccinated, and if you measure their antibody years later, you won't be able to measure anything. But we know that those people, if they're exposed to hepatitis B, their body recognizes it and the cells start making antibodies. So we just don't know where this is going to land, you know, this COVID virus and the immunizations. So I think it's a combination of getting people vaccinated and the whole herd immunity idea that hopefully can bring the numbers down so that we can get back to a more normal existence. And what no one knows yet is this something that we're going to have a yearly vaccine for, or is it something we're just going to need a booster vaccine for? People just don't know yet. I mean, it may turn out that immunity is much longer. We can hope. I think time just has to pass for people to figure that out. But you're right. I mean, I've thought of that. If I get vaccinated now, what does that mean for me in June? You know, I don't know.
Thank you.
And
Quick, Master,
yeah, please go ahead. Yes, sorry.
one quick question. We have 2 more vaccines on the horizon, AstraZeneca and J&J. Any idea of when those will be in the pipeline and available?
I don't know. So, you know, there's all kinds of safety processes that all these trials have to go through, and then they're presented to a vaccine board and the FDA. So I don't know where they are. You know, as you know, the AstraZeneca, I guess, has already started to be used in the UK. So maybe it won't be that far behind here in the United States, but I don't have that information.
Thank you.
And I have one more question. Let's see. Does your blood type affect your COVID-19 risk?
So honestly, I've seen the titles of those commentaries or articles, but I haven't read about it. And I haven't heard anybody really bringing that up, you know. So when I listen to Stanford Grand Rounds or, you know, people on webinars that are very well known throughout the country, I don't really hear anything about blood type. So I can't honestly comment on that because I don't know. All I can say is I'm not hearing anyone bring it up saying, wow, look at this, you know, so I don't know.
Okay. Thank you.
Sure.
Okay. All right. Dennis?
Thank you for your time, Dr. Gooze.
My pleasure. Thank you very much.
Yeah.
I hope it was helpful.
You want to say something else, Worshipful Master?
Of course. Yes. Thank you, Dr. Gooze. It's really a pleasure and honor having you here tonight with us. We're really thrilled that you could share some of your time. I know from your busy schedule, it's probably crazy, especially around this time, but we really appreciate your presence here tonight and that you could actually afford us the opportunity to hear it firsthand about the vaccine and be able to ask direct questions about it. So really appreciate your time. Thank you so much.
No problem. You're welcome. I hope it was helpful somewhat.
Very much so. Thank you.
Okay.
Thank you.
Thank you. Have a good evening.
Thank you.
Good night.
Thanks. Good night.